Hello, my friends. Bruno Leitão here from Portugal, from my house in this period of quarantine to do another case discussion, this time on a lower AO4. Let's all try and keep our minds working while this period lasts. So, I'd like to talk to you a little bit about the AO4 concept and on this case of a lower AO4. The all-on-4 surgery is a surgery that we do often in our clinic. It's one of the surgeries that can easily provide immediate loading conditions and restore a full arch in a couple of hours. Me and Dr. Nuno Gaspar, another fellow knight from Lisbon, were planning to do a workshop on the China International Symposium that was postponed on this subject on AO4. We hope to do it in the near future. So, in this case, a lady, around 65-year-old also, came to us looking for a solution, aesthetic and function solution. On her upper jaw, she wears a full removable denture. And she was happy with the function, not happy about the aesthetics of the denture that she was using. Her main problem and her main reason to come to us was her lower arch, because she had failing teeth, a lot of roots, a lot of teeth with severe decay, and also chronic infection. You can see on the lower right image there is even a fistula around the midline. So we take pictures, we talk to the patient, we try to find out exactly what the patient wants and needs and what it is possible to do, and try to find together the best option for each patient. So when we look at the CPCT, we can see that this patient has enough bone between the mental foramen to do this kind of surgery. And in the posterior aspect of this anatomic landmark, there is not a lot of bone. So we try to keep things easy as possible. And in this case, we can also see that the bone, of course, and usually it is this way, is maintained around the teeth. So we get irregular bone process anatomy. And we plan for a AO4 case. Again, me thinking about how is the better way. Can you see the profile resemblance? So this is on a 2D our planning, quite direct planning and quite easy planning. But we can see that the vertical position of the platform of the implant will need a large bone reduction in order to be perfect. So, one of the main aspects while performing AO4 surgery is to keep our anatomical landmarks quite clear. If we are doing it on the upper jaw, we have to know where the anterior wall of the sinus is. And if we are doing it on the lower jaw, we have to know where the mental nerve bundle is. So, my advice is for you to open a big flap and make sure you elevate that flap in a way that you can see perfectly where the mental nerve emerges. And when you see it a little bit on the coronal aspect of the ridge, you can mark it. You can use a pencil. Maybe the saline will remove it. I like to use a round burr and make a 2 millimeter round burr and make a small hole on the most coronal aspect of the ridge near our mental emergence. That way, during the surgery, I just have to check where that bone mark is, and it's quite simple and quite safe to do the surgery in this manner. After the removal, the elevation of the flap, we need to address the bone pathology. And when we have this kind of decayed teeth, we usually get what you see on the right image. you get a lot of infection tissue that we need to remove thoroughly, and we get this irregular shape bone. One other thing that we must be absolutely clear of the position is the midline. The midline is critical to set the standard for this kind of surgical technique. So the ridge that we get after the extraction, in this case, we get this kind of ridge. It looks like the Everest skyline. It's so irregular. We were in Nepal a couple of months ago, my friends, and this was a big reminder of this kind of anatomy that we see. And we also can see that the buccal wall around the sockets is fully destroyed because of the infection that this patient had. So it is impossible to place implants considering this vertical limit. We have to get a new vertical limit, and we have to flat this ridge out. So we will look at another case just to see the details on a bone reduction and what a bone reduction can do for us if we are thinking about this kind of one-piece protocol. And you can see that in this case, a similar case, when we open up our flap, you can see the residual ridge, and where up in the teeth the patient still has, we have like a sky-high bone wall. And of course, we need to do the bone reduction. And we can get from this thin, high ridge on one side and get this kind of implant placement. We get a large plateau where you can safely place your implants, keeping enough bone to the buccal and keeping a nice plateau for the denture profile we'll see a little bit further in this presentation. One other thing you can see in this picture, you can see the marker of the midline. You can use, of course, the All-on-4 guide. I think in this case we use that guide, but I don't always necessarily use the All-on-4 guide, honestly. I find it easy to do marking the midline, seeing the anatomical landmarks. For me, it is quite simple to do the surgical that way. One other thing that I do is I look at the bipopular line of the patient. I take a step back during the surgery, and looking at the bipopular line of the patient and the bone reduction, it's easy to see if our horizontal bone reduction is perfect or not. One other thing you can see in this image is the placement of the ani-ridge, a below bone placement of the implant. But this bone, as we'll see next, can make the installation of intermediate abutments harder, of course. So back to our case, and back to that Everest ridge we saw, we are going to use a gouge to remove most of the bone, like I talked about in the first video I've made, and then a big round burr to make the ridge as smooth as we can. And then, knowing where the midline is and the anatomical landmarks are, it's quite easy to place the implants. Usually we place two vertical in the middle, and the posterior implants can be tilted up to 30 degrees. And in this case, we had this kind of guide coming from our provisional prosthetics making that can help you select and install the correct intermediate abutments. In this case, octa on the anterior and multi-unit on the posterior implants. And you see that the emergency is quite good considering our tooth positioning. And when we look at from taking a step back, you can see this on the patient, a beautiful image. I love this image here. And you can see the distribution of the 4 implants. As I was saying before, when you get the implants, and any ridge implant should be placed below bone level, it can be quite difficult to install, or impossible to install, the intermediate abutment, the multi-unit, without this tool, the bone profiler. and you can get it from your dealer. So on the right you have a small piece that you can screw to your implant, and on the left you have a piece, the profiler, that will go around that first piece and remove all the bone without damaging the implant platform. Doing this, you can then install your multi-unit without any bone interference, and it will fit passively in your implant. And this is critical. You have to do this before you take any impression or do any pickup for the provisional. Otherwise, the error will go all the way to the end of the work, and you will have to do all the prosthetics again. So, you can see here on an upper case, you can see here on the left X-ray with the multi-unit not fully seated. And on the right, after correction of the bone profile, when it is fully seated. Make sure you check this. Here in this image, we've already installed, back to our case, we have already installed our provisional titanium cylinders because we are going to do immediate loading in one of the ways that I usually do. I'll explain to you two of the ways that I usually do it. I hope in the case discussion other colleagues tell me how they do this, because this is especially for a surgeon, this is the most difficult part that I find during this procedure, and I'd love to know other options to do so. And again, we are checking the emergency of our implants, of our abutments, making sure everything is in the right place. So in this case, we decided to do a pickup of the 4 titanium cylinders. And for that, the first thing we need to do is to install a rubber dam, because we are going to use acrylic inside the mouth, and we don't want that acrylic to go to our wounds or to our sutures. Then we must block, this is really important, I use usually some Teflon to block the access to the inner part of the titanium cylinders. Otherwise, the acrylic will go in and you have a big problem. You won't be able to unscrew it from the mouth easily. And this EasyBar system that I like is made out of hundreds of these metal pieces you see here, stock pieces, and you can select the length of pieces and adapt it to your case. In this case, we use 2 longer bars on the posterior, between the posterior and the mid on the same side, and then a smaller one between those 2 on the anterior. So with this kind of union between the temporary cylinders, we are absolutely sure we have a passive, precise fitting of our prosthetic. And then we can get our prosthesis that was previously done fully open on the lingual, and we know it's going to work out beautifully because we've already tested it with the surgical guide, and we can install it, make sure the patient bites on the right position, and then remove, unscrew it, and our lab technician can finish the entire piece. And when it is finished, it should look like this. You see, this is the lower profile of the provisional, and you can perfectly see where the pickup acrylic is. And of course, we need to make sure that this profile is not retentive in any way. Otherwise, debris will get stuck and food will get stuck, and the patient will not be able to clean it. Even if the patient works a lot, works hard, won't be able to clean it. So make sure that the prosthetics have this kind of profile, a convex profile, okay? Not this kind. Otherwise, it would be impossible to clean for the patient, and we will get inflammation and problems during this initial phase. And you can see in this patient, I decided to unscrew the prosthetic 15 days after the surgery because there is a small inflammation over there, and I decided to remove a little bit of the acrylic, not to press so hard because of the soft tissues. And one thing it's easy to see is immediately after removal, the wound is clean and you have that nice plateau we have talked about in the start of this video. So this is quite critical. Also, by doing this, you get the correct vertical restorative space that is critical for low prosthetic complications in the future. So this is the case on the day of the surgery, finished prosthetic screwed in the patient, and we are happy about it. The occlusion seems to be stable, and you can see it on the using the articulating paper, and the aesthetics are okay. I'm okay with this. Of course, we need to change something in the definitive stage, but I'm absolutely happy about this, and so is the patient. On the upper left, you can see the EasyBar system X-ray. You can see if you don't have a cantilever, it's going to be really hard to get fractures with this kind of system, at least full fractures of the prosthesis. Of course, some tooth can break, but it's going to be impossible for the prosthetic work to break in two. And on the right, you can see the full zirconia work some months afterwards. You can also see that by tilting the implants, we were able to use longer implants, and this is one of the main advantages of this technique, because by doing so, we can usually, or I wouldn't say 100% of the times, but really near 100% of the times, we can get immediate loading conditions. And this is what our patients want. This is what we want, because it makes everything much easier if we are able to do immediate loading, especially on full arch cases. And here we can see the evolution of this patient on the day she arrived, on the day of the surgery, and on the day of the final zirconia one-piece seating. The patient is happy. The patient is looking beautifully. The patient even went to the hairdresser, and she's happy and confident. And so are we, because we know this is predictable. That's for sure. Considering immediate loading, one other way I do things, and this is also a lower, not all on 4, but all on 4-ish case, because we didn't have the need to tilt one of the implants, but it's a full arch on 4 implants. You can call it what you want. But you can see the surgical principles, the same as in this case. Open up a big flap, tooth extraction, make sure you have a nice plateau, place the implants. And in this case, to do the immediate loading, what we did is, of course, we had the prosthetic previously almost done, right? In a similar way, in this case, I didn't use any bar, I used a rubber dam, and all the transfers were united with old burrs that I keep in my clinic sterilized, of course, and in a similar way to the EasyBar can help us splint the implants to do our open tray impression, a usual open tray impression. But because we already have the prosthetics in our office, we can open it just a little bit on 2 of the temporary cylinders and place only 2 in the mouth, temporary cylinders, screw, and because they are open in the buccal, when you ask the patient to bite, it's quite easy to inject some acrylic just to pick up those 2 cylinders. Of course, you have to do a bite register and send it all to your lab technician. And with that, some pictures also, he will be able to finish the work. In the middle, up, you can see the patient on the same day. Absolutely thrilling to see that smile on this elderly woman. And on the first panoramic exposure, you can see the same day panoramic X-ray, and the final zirconia, similarly to the other case. On the lower, in the middle, you can see 3 months later, when the patient comes for a control and go for the full zirconia restoration, you can see the beautiful soft tissues, the color, you can see that beautiful pink, and you know everything's going to be all right. And this is a happy patient. Happy patient will mean a happy doctor. So please tell me how you do these immediate loading procedures. For an oral surgeon, I would say that this is the most hard part of the process, and I would love to have somebody to do all of that for me. So, my friends, stay safe, keep in touch, visit the Megagen homepage at imegagen.com to see some of my colleagues presenting also their cases. Most of them are much better than me. Bye-bye.